I'll introduce Peeyush. As I said earlier, Peeyush is again my former fellow from SGPGI, and now he's at the All India Institute of Medical Sciences in Jodhpur, and he's the one who has been managing the Friday afternoon Jaipur Surgical School. Peeyush, please.
Thank you, and good evening to everyone. First of all, I'd like to thank Professor Kapoor for this opportunity. So my topic is small bowel and anastomotic leak, including the right hemicolectomy. Although it seems to be easy as compared to other anastomotic leaks like esophageal or a colorectal anastomosis, but it is as important because I think every general surgeon and a GI surgeon will perform or is performing these anastomosis day in and day out. So just a brief introduction. So anastomotic leakage has been the bane of intestinal surgery for almost a century now. There has been a leak rate varying from around 1 to 2% to almost around 25%, depending upon the site of anastomosis. Around for right hemicolectomy, the leak rate is around 8 to 10%, and for small bowel anastomosis, it is around 1 to 5%. So anastomotic leaks increase the length of hospital stay. They have high readmission rates and higher mortality. So when wherever the reoperation is required, it creates a negative impact on the quality of life also, as well as a great financial loss to the patient as well as to the family. Although various surgical techniques and interventions have been developed to mitigate these leaks, but no effective solution is available. To define what is an anastomotic leak, it is a defect in the intestinal wall at or near the anastomotic site, including suture or staple lines of any neo-reservoir, leading to a communication between intra and extraluminal compartments. Any abscess that is close to the anastomosis is also considered an anastomotic leak. So it can be after any surgeries. I'll be particularly dealing with the small bowel anastomotic leak. This is a study, more a review article from multicentric middle-income countries, where they have depicted various leak rates after particular different anastomosis, and they have also highlighted that what an anastomotic leak can lead to. So there is an increased 18% mortality. It can lead to increased hospital stay and as well as additional cost due to increased hospital stay, patient trauma due to more formation of stomas, as well as decreased quality of life and patient discomfort. So why does it leak? So as already covered in the previous talk and will also be covered subsequently by Professor Vishal. So the mechanism of action for the leak is depending upon the site specific as well as local factors such as tissue and cellular morphology. What are the local digestive enzymes that are present there? What are the general and local tissue conditions? And most important is for what the surgery is being performed, especially in small bowel when the surgery is performed for tuberculosis, Crohn's disease, and other situations like mesenteric ischemia. So their proposed solutions can therefore differently vary according to the disease as well as the site. So it has always been debated that whether there can be a zero leak rate, but yet to encounter any study that can say that there is a zero leak rate. But yes, there can be certain measures and preventive measures which can decrease the leak rate. So I think these factors have already been covered in the previous talk by Dr. Anshuman, that the certain factors are modifiable and certain factors are non-modifiable. So among the modifiable factors are like preoperative, smoking, alcohol consumption, obesity, malnutrition, patient's albumin and protein level, stopping the NSAIDs, mechanical bowel preparations, and a preoperative systemic therapy. Intraoperative factors like vascularity of the bowels, type of suture material used, type of anastomosis, stapled or suture, type of approach, and whether the anastomosis diverting stoma is used or how many blood transfusions are there intraoperatively. Non-modifiable factors are also there, such as like sex, comorbidity index, prior radiotherapy, or the tumor, the location of the tumor. So these factors are non-modifiable. There are certain strategies that can be used to prevent these leaks, but all these strategies have been described in literatures but have not been propagated so rampantly because the effectiveness is not been studied and its use is also not so frequent. Certain platform like sealants, which can be biologic and synthetics, have been used. Patches like biological patches from collagen, synthetic patches from polyglycolic acid, and interluminal device like C-seal, mechanical methods like suture, clipping. All these methods have been used, and like improved surgical technique. Recently, Dr. Anshuman discussed about the indocyanine green and other methods such as omental wrap. So every strategy has a pros and cons depending upon its property as well as the use. So these are certain advantages and disadvantages of these mitigation strategies. Like fibrin sealants, although they have a physiological sealing, but they do not form any adhesions and they have a rapid metabolism. And similarly, synthetic sealants have strong adhesions and create a strong inflammatory reactions. So they may increase post-operative adhesions and obstructions. Similarly, biomembranes in patches, they have immunogenicity and create a foreign body reactions. Certain Murphy button or endoluminal stents can create a rigidity and foreign body reactions and also lead to luminal stenosis. Similarly, omental wrap can also lead to adhesions and strictures, which can lead to post-operative obstruction. So all these strategies are there to reduce the anastomotic leak, but despite all these strategies, the anastomotic leak will happen and has to be managed very carefully. So how an anastomotic leak can present? It can present in any way like peritonitis, pelvic, any abscess, pain, fever, tachycardia, or purulent or a feculent discharge from an abdominal drain placed during the surgery. So the diagnosis is quite easy if we are following the condition of the patient very carefully. And patient may present with fever, abdominal pain, distension, nausea, vomiting, and sometimes drainage from the surgical wound. Physical examination will lead to tachycardia, tachypnea, and signs of peritonitis. On investigation from blood investigation will obviously show the leukocytosis with neutrophilia, and cultures may be sent to identify the associated bloodstream organism, and electrolyte imbalances and markers of organ dysfunctions may be sent to assess the other organs functioning, such as serum creatinine and hypoperfusion of the organs. So first and foremost, if after stabilization of a patient, the gold standard image, the modality used for the diagnosis is the CT abdomen with oral and IV contrast. So, like we see in this picture, we can see the extravasation of positive oral contrast from the anastomotic site and other indicators such as free intraperitoneal air as well as enhancement of the peritoneal lining. These all indicates the anastomotic leak. Another picture which showed that the anastomotic leak from ileocolic anastomosis tracking down the abdominal wall through the wound. So all the just to highlight that the CT is the gold standard for diagnosing an anastomotic leak. In some cases, a water-soluble contrast or a swallow study may be performed to evaluate the integrity of the anastomosis, especially for the esophageal anastomosis. Other modalities are used mainly for endoscopy, mainly for duodenal anastomosis may be used and to assessing the upper GI anastomosis, but rarely used for small bowel anastomotic leaks. And also drain fluid analysis can be done if we suspicion anastomotic leak, which is not obviously frank. Regarding the late leaks, they have insidious presentation with low-grade fever, prolonged ileus, and sorry, non-specific symptoms. Small contained leaks may mimic post-operative abscess, and they are usually underreported and not counted as anastomotic leaks because of their varied presentation. So these are some of the real-time, real-world clinical photographs in which our patient presents as an anastomotic leak. This is one of the patient having feculent discharge from the main wound. This is another photograph in which the reoperation was done for anastomotic leak and suture line dehiscence was found, and then subsequently the abdomen was plastered and patient was managed with wound manager. So how to manage the anastomotic leak? So basic principles remains the same for any anastomotic leak, that to control the sepsis, to take care of the nutrition, especially the enteral nutrition, if required, nasojejunal tube or a feeding jejunostomy, And then finally, when the sepsis and nutrition is taken care of, to delineate the anatomy and to plan out what can be done next. So multiple factors are important. Most important is the what was the surgery done for, especially in the cases of mesenteric ischemia, tuberculosis, as well as Crohn's disease when the primary bowel is not healthy. So the management of leaks become difficult in these scenarios. Another important thing is the site. So the duodenal leaks are usually difficult to manage as compared to small bowel leaks. And when in small bowel, the proximal jejunal leaks are difficult as compared to the ileal leaks. So another factor is the duration. When is the presentation, early or late? And then depends what kind of management we are going to follow, a conservative or a surgical management. A word about duodenal leak. Duodenal leak is demanding and the situation is also rare. It may happen only after when we have performed surgeries for like excision of a duodenal gist, or we have repaired a duodenum during some other surgery, especially for a gallbladder cancer or cholecystectomy, and there is a dehiscence of the suture line of the duodenum. So the approach needs to be tailored in case by case fashion and depending upon several parameters. Most important are the interval between the operation and the diagnosis and the general condition of the patient. So if it is diagnosed early within 4 to 7 days or less than that, then surgical revision or resuturing appears to be a feasible option if the risk of further damage is low. But with increasing time, the success rate of surgical closure decreases, and it increases the risk of further injuries. So then the decision of surgical reintervention is made based on the surgeon experience and the expertise available. So the treatment options available for the duodenal leak can be primary closure or coverage from serosal flap or duodenal gynostomy, or do a segmental duodenal resections, put a drainage tube for biliary diversions, and finally for a Whipple's procedure that is more technically demanding and should be carefully selected. IR may play an important role, especially in managing the collections, especially in duodenal leaks, when putting PCDs for undrained collections as well as PTBD for diverging bile. Nowadays, endoscopic facilities are also available at the centers of expertise and can be utilized to mitigate the effects of duodenal leak by duodenal stenting, CBD and pancreatic stenting, nasobiliary drainage for diversion, and NJ for nutrition. And other supportive measures such as antibiotics, somatostatin analogs, loperamide, parenteral nutrition, wound care and protections are important part in managing the duodenal leak. In case of a post-operative duodenal leak, spectrum of possible procedures is almost similar for the management of difficult duodenal stump. And if the primary suture of duodenum in the first operation was performed, then attempt to resuture should not be taken up, and because there will be a chance of leak subsequently. So other measures should be used as described in the previous table, like a duodenogenostomy can be performed, and additional biliary diversion procedures can also be performed. If all these procedures cannot be performed, then decision for resection should be taken very carefully, whether it has to be resected or multiple drainage has to be put down. Emergency Whipples is a very demanding procedure with high morbidity and has to be considered carefully in only in the centers of expertise. Controlled surgical drainage in these situations is rather a more feasible options with placement of catheters into duodenum and other undrained places in Morrison pouch, and basically the goal is to make a stable fistula and do a resurgery when the patient is in a cold condition. So both surgical and interventional therapies have been accompanied with pharmacological therapies as described in the table. Antibiotics, fluid replacement, and parenteral nutrition also play an important role, especially managing the duodenal leak. Now coming to the management of small bowel leaks. In contrast to duodenal leaks, isolated small bowel leaks are rare and also easier to manage. If detected in time, they can simply treated by additional resection and reanastomosis. However, most leaks occur as complications in more complex settings, such as peritonitis or multiple revisions, open abdomen and frozen abdomen, like cases of mesenteric ischemia and tuberculosis. So, like I already described, similar duodenal leaks, surgical revision should be adopted if the general and the local conditions allow and the tissue is healthy. But if there is increased duration of leak and associated peritonitis, then the surgical revision may not be feasible. So other interventional therapies should be used for managing these leaks. And often when the primary closure is not possible, Then if there is only an isolated segment which can be resected and reanastomosis is done, should be performed. If the reanastomosis cannot be performed, the bowel tissues are not healthy, and we think that the anastomosis is going to leak, then making a stoma is a more feasible option and a safe option. Although making a stoma is safe, but it can lead to post-operative complications like stomal problems as well as small bowel syndromes associated with abdominal wall defects. So the decision should be made very carefully. And in complex situations with multiple enteric leaks, even a proximal genioscopy can also be considered if no other option is available. In cases of recurrent leaks or frozen abdomen, all other options are impossible. Then obviously we have to do a bailout procedure, and placement of wide drainage catheters or applications of a vacuum assisted system over the entire abdominal wound can be used. And then subsequently the patient can be managed as a controlled enterocutaneous fistula. So just to summarize that the principles of surgery when we are going in for a small bowel anastomotic leaks remains the same. That is minimizing the extent of surgical intervention, shortening the procedure as much as possible, adequate drainage and diversion wherever necessary. These are my concluding slides. These are certain recommendations from, although not from small bowel point of view, but have been by the Rectal Cancer Society, but holds true for the small bowel also. So they have divided into 3 grades just to categorize the patients and to manage these patients easily. And they have divided into 3 grades, A, B, and C. In grade A, the clinical condition is good and with contents from the drain are usually serous, and patient general condition is good, and radiological evaluations also demonstrate a small or contained anastomotic leak. So generally, a conservative management can suffice, and there is no additional or increase in the hospital length stay. In grade B, there is usually abdominal pain, fever, or there is some discharge from either the catheter or the wound site, and it may require additional intervention in the form of percutaneous drainage and antibiotics. Grade C is finally the patient is in florid sepsis and peritonitis and will require a redo surgery in the end, possibly a diversion. So this is a algorithm for managing a suspicious anastomotic leak. If the patient general condition is not good, then patient is having severe sepsis and peritonitis. Usually, patient are directly taken for laparotomy for either a stoma or a resection anastomosis. And if the patient condition is stable enough to get a CT scan, then always be evaluated with a CT scan and then accordingly graded as described in the previous table. Grade A can be managed conservatively. Grade B, if they are only small abscess, they can be dealt with antibiotics. Larger abscess may require percutaneous drainage, and larger abscess that are radiologically inaccessible may require surgical drainage. And in this algorithm, if always a patient deteriorates or patient develops signs of peritonitis, laparotomy is the only option, and to create a fecal diversion. Just to complete the list, endoscopic options are also available, but not commonly used for small bowel anastomotic leak. More commonly used for esophageal and colorectal anastomosis, like endoscopic clips and SAMs, and the endoluminal sponge therapy can also be used and will be dealt probably in subsequent talks. This is one of the image of through the scope clipping. This is my last slide before the summary. This is the study recently published in British Journal of Surgery in January and has been very popular and got almost more than 50,000 views, 15,000 views in last 3 months. So what they did was they took the surgeons from low volume centers from middle and low income countries and give them a strategic modules and step by step modules to educate them and inform them about the techniques of the anastomosis. And what they found was there was almost reduction in everything, starting from clinical leak to death rate, reoperation, readmission, duration of hospital stay, unplanned admission to ICU, and making of unplanned stomas, and defunctioning ileostomy with primary anastomosis. So they found that almost the leak rate reduced from 12.2% to almost 5% after intervention in high engagement centers. So the take-home message is that anastomotic leak is a severe complications and can be fatal, so should be taken very seriously as it can increase the morbidity and mortality. And if there is morbidity, it might delay the further chemotherapy, especially in cases of malignancies, and it may decrease the long-term survival. So early recognition and suspicion is the key to management. And there are various management options depending upon the general condition of the patient and when the leak is detected from operative to non-operative. And obviously, prevention is better than cure. So various techniques which can be modified and anastomotic leak can be prevented should be adopted. And as already discussed, there is no role of routine diverting stoma to prevent anastomotic leak. Thank you.
We can have 5 minutes comments from Dr. Supe and Dr. Sitaram before we move on to the next.
Okay, I'll start, sir.
Yes, yes, please.
First is Dr. Anshuman, actually. Anshuman, I think very nice presentation. You covered most of the points. I think I have only one or two comments to really make. One is, I think we have been using now ICG very often for colonic anastomosis, especially when we are doing it, and it is very useful. Especially if you are in doubt, I think ICG is very useful, and you have to really give it about few minutes before, and usually you see the bowel very well. You don't have to give it 2 hours like they give in the CBD. Immediately you give it and you are able to see, and you are able to really then get an idea about your colonic level, especially. The second point I wanted to make was in an ischemic bowel, if you are doing anastomosis, usually there are many, and we also don't put clamps actually. We don't put intestinal clamps. We try to do anastomosis without clamps. And many times we do single inverting rather than the classical, the double layer anastomosis. Because I think in an ischemic bowel, if you're doing anastomosis, we have to be a little more careful, and you don't have to put clamps and do that. There were only 2 comments, and I wanted to ask you one question. Do you test the integrity of your anastomosis many times, especially in the lower colorectal or esophageal, and like putting water and then injecting the air or something like that, and how helpful it is in the literature?
Sir, a very nice question. Wherever we have an access, it is we prefer to do it, especially in upper part, whereby a nasogastric tube or any kind of tube is there. Especially in laparoscopy, we always do that. Regarding the lower component, of course, we use an asepto syringe, as we call it, and then subsequently we just push in a bit of air. The important thing is that it should not be very vigorous. It should be gentle. And sometimes previous teaching was that you should not even try and do a very hard per rectal examination or try and do it. Why? Because you may actually jeopardize your anastomosis. But nowadays we do a gentle PR and we put in a bit of saline and subsequently try and look for any kind of on-table leak, as we call it. And literature, of course, we have got a few, it's individual rather assessment. We do not have a very large component. Even Professor Rajan had actually suggested something about it regarding the insufflation techniques in hepatobiliary surgery. And we have done that in bits and pieces. And if it is accessible, yes, we'll always do that. Sometimes to push in a saline or air, whereby we do not have an access, may be questionable. It may be counterproductive sometimes, whereby you are doing it at the evening after you're tired whole day of surgery. You may actually do a lot more harm. So nasogastric tube, having your anesthetic backup, doing the things, especially in any kind of anastomosis in morbidly obese patient, in challenging patients, yes, of course, it is a must. And wherever we have access in this thing. And we've also tried to do that in a small bowel. Of course, we mobilize contents and put it in a kidney tray or a kidney bowl. And it is a no-brainer that you should do it. But having evidence, I'm not very sure.
Second question I wanted to ask you was that do you take over the sutures over the staple? There are many people who, after doing stapling, take another layer with hand with the submucous, subserosal kind of a stitch, layer they take over the staple line. Do you really?
Okay. So personally, sir, in open surgeries, we used to do that while we had 2 layers of staple. Nowadays, we have got 3 layers of staple, and I think so it's an overkill sometimes that you try and do that. We have tried that in duodenal stump, especially in gastric carcinomas, and the distal gastrectomy, as we call it, the radical distal gastrectomy. And we have used sutures, predominantly proline, to actually bury the mucosa under the serosa. But I did not cover it because I thought that it was unnecessary for my talk. The staple form a figure of 8 kind of a scenario, whereby the mucosa is actually goes inside. And frankly, we have to understand that there are 3 layers doing roughly the same thing. How they do it is kind of questionable because we have to actually see it under the microscope sometimes maybe. But still, the lowermost layer is the most important. And what we have done essentially is that once we take out say we are doing a sleeve gastrectomy and we take out the specimen, we actually see the specimen also. And sometimes you stretch the specimen and you see the integrity. It is quite sturdy. So using perforce another layer of sutures may sometimes be unnecessary.
I fully agree with you. It's something like, if you look at the evidence in the literature, I think you will find single inverting is as good as doing double inverting, double layer. But I think most of us still prefer to do double layer inverting. I mean, that is what is probably it's mental kind of a thing which you get. We are not very happy many times with doing only single inverting, though literature is very clear that single layer inverting is as good as the double layer inverting. So I think these are some practices people follow. So we need to really look at those evidences and see how worth they are doing it or worth they are not doing it actually. Sitaram, you want to ask any questions?
Dr. Sitaram, any comment?
Yes, I have a few comments. I quite enjoyed both your talks, Anshuman and Peeyush.
Thank you.
Anshuman, I think one of your key slides was anastomotic leaks are caused by poor technique, vascularity, and tension. I think that is the key thrust, should be the key thrust of your presentation. In vascularity, personally, I feel that if you can see blood vessels close to the transaction margin pulsating, the arteries pulsating and the veins not being black, that is a very good indication that the vascularity is good and tension is quite obvious. You mentioned a large number of techniques of suturing. Whenever we have many options, that means we don't know what we are doing. We as surgeons collectively don't know what we are doing. So we should adopt for something that is simple and replicable in our hands. And I think nobody can say it better than the master Leonardo da Vinci. He said, simplicity is the best elegance and sophistication. So a simple technique of anastomosis using a monofilament suture which coapts bowel well is probably the best technique. You rightly said that one important consideration in stapled anastomosis is the bowel should not be edematous. And I think that has to be underlined. If you have edematous bowel, especially in the emergency situation, you should not use staples because those anastomosis that you create in edematous bowel are bound to fail. The other comment I want to make is the cost effectiveness of staples. We should not go away thinking that staples are an answer to many of our problems. I don't agree with that. We are still not a developed country. 2047 is still very far away, and we are a developing country, and surgery done in very small hospitals in the periphery. Surgeons should not think that stapled anastomosis is superior and I'm doing something inferior. I personally feel in those situations, a well done hand-sewn anastomosis is better than stapled anastomosis. And Peeyush, one of the things that I would like to say about reoperations for anastomotic leak, you have not mentioned abdominal compartment syndrome. At the end of the operation, very often, edematous bowel, you are unable to close the abdomen, and one should have a low threshold for closing only skin with a resultant large incisional hernia. but it's much better to have a live patient at the end of any operation. Thank you.
Peeyush, I just wanted to add one simple point. Actually, you said very rightly those international guidelines, but I think people, I mean, in addition to the clinical judgment, I think we should also do CRP and TNF levels. These have been now recommended by many these guidelines that they help you in making an early diagnosis of a leak, especially in colorectal lesions. Though I don't know, we mainly use C-reactive protein. We don't use TNF alpha. And secondly, I think you said about WAC. WAC I have found very useful, especially in some of these below the peritoneum, lower rectal leaks. They really help you well. And if you really do that, then WAC, especially that we have found it useful. Even in some cases of the esophageal leak, we have found endoscopic WAC very useful. So I think these are two areas of endoscopy which have been found useful in controlling these leaks, which are localized, I think. And that's where we should really use them.
Yeah.
Thank you, Peeyush and Anshuman.